Today we are going to have another session of case series in bipolar disorders. Thank you very much. Thank you all of you for being here once again. Today, what I'll do is that there are a few questions which have come up. First, let us see that now, almost about quite a few have come up. I'll take up some of these questions and maybe first about 10-15 minutes, let us spend some time on this discussion. I think all of you know that I will not be able to answer all the questions, but I'll try my best to the extent what I can do. And then we'll move on to the case discussions. There are 3 cases here. All of them are youngsters and then males. And then once we have the case discussion, then maybe we can take up once again the questions. Today it's really a pleasant surprise that there are actually about more than 60 questions. Some of them have come a bit late. About 40 questions I could get it into the slide form. I want you to just run through this, about 20 questions here, and then in the next slide about 20 questions. After that, let me see a few of the points I can take up, and then let me see to what extent I can make an attempt to answer, spend about 10-15 minutes on that. So I think it's very good. Some of the questions are very, very important questions, and especially something about OCD and bipolar disorder. This is one of the major areas I have problems in that. And then these are the few questions which have come, and then the other set of questions are this. I am sure you are able to read some of these questions which are here, and some of the so-called questions what I felt important, I try to highlight them so that maybe some of these will take up, and the other questions we can take up maybe while during the discussion, or maybe later. So if you can I think you're able to just run through the different questions. Maybe some of them are repetitions also are there, and then let's see that. Then now let me for a few minutes, let me stop sharing this and then answer some of the questions. The very first question is, which is better, lithium or valproate, in terms of efficacy for younger males? Now, actually, the question is not, is it in acute mania or acute depression or prophylaxis? Nothing is there. But whatever it is, for my eyesight, I'll say definitely lithium. How to identify rapid cycling? It's not all of us know, sir, it's 4 cycles in a year. And fortunately today, one of my patients, what I'm going to discuss, he has got one a rapid cycling episode, which I'm going to. How is bipolar disorder different in females? I don't think broadly is there any difference between bipolar disorder presentation in females or males, but the management wise we have a lot of problems, because almost all the so-called prophylactic drugs like lithium and valproate and all these drugs will have its problems during pregnancy. But otherwise, keeping that aside, as somebody who is more interested in mood disorders, I always felt somewhere the secrecy of neurobiology of mood disorders lies in unraveling the hormonal dysregulation of a woman. Why I feel is that you look at the PMDD, premenstrual dysphoric disorder, which comes for just about 3-4 days or 4-5 days. Every cycle, quite a few significant women have that. I call it as a miniature version of recurrent major depressive disorder. That's very clearly linked to the female hormonal systems. Number one. Number two, postpartum recurrence of the mood disorder is very high. Once again, it's related to the female hormonal dysregulation. Very definitely. These two, PMDD and postpartum episodes, where the mood disorder episodes are very high, I think are strongly linked to the female hormonal system. And we all know that MDD is twice common in women compared to men. So with these 3 points, I always feel that somewhere the secret lies in, maybe estrogen, progesterone, whatever it is there somewhere. We have to focus more on that. I think we are going to get the facts of neurobiology there. And evidence-based management of bipolar disorders, I think we all follow evidence-based management only, but sometimes the efficacy may not get translated into effectiveness and thing. Quick diagnosis of bipolar. I don't know, sir, quick diagnosis, but at this point, let me tell you, of all the psychiatric disorders, I think as medical students, we all have gone through clinical examination. In the medicine clinics, you have a long case, you have a short case, you have a spotter. In psychiatry, in the clinical examination, if there is a spotter, that will be elated grandiose mania. Absolutely. You walk into the room, patient walks into your room, 2 minutes, 1 minute. Hi doc, how are you? Till yesterday you think, Doc Saab, kaisa hai sab? Spotter. Elated grandiose mania can be a spotter once you have a definite elated mania. It is bipolar. That's the only situation I can say, that quick diagnosis of it. And then step BD trial. I think, sir, we will take it up sometime. Briefly, I'll say that systematic treatment enhancement program of bipolar disorder. This is one of the largest naturalistic studies. Main principal investigator is Gary Sachs. About 4,000 patients were recruited into this. It's a naturalistic study. This is the first study which gave us the first indication saying that antidepressants may not be effective in the management of bipolar depression, but there are now like a lot of other factors also sometime later, like STAR-D in MDD, STEP-BD is in BD. Cognitive recovery and neuroantidepressants maybe take it up later. At present, it's not related to that. What is the efficacy of lamotrigine in comparison with valproate for prophylaxis? Lamotrigine has nothing to do with mania prophylaxis, sir. It's only for the depression prophylaxis. What is the course of OCD in bipolar disorder? I think this is actually, there are 3-4 questions which have come up. The relationship between OCD and bipolar disorder. I'll just now once again show the slide, which is now right. What is the course of OCD in bipolar disorder? This is a very, very important thing. I run a bipolar clinic, Asha bipolar clinic, but under that I say that clinic for mood disorders and OCD. Actually today, I am more confident after this question came to talk about it, because generally, what is the relation between bipolar disorder and OCD? Bipolar disorder is a psychotic disorder, OCD is a neurotic disorder, it's a continuous this episode, all sorts of things come. But there are quite a few occasions where initial diagnosis was bipolar disorder, later it became OCD. I have seen that. That is why my interest in OCD is also a little bit more. I think the course of OCD, it can be different types, sir. It can be OCD plus bipolar disorder, 2 disorders together, or OCPD getting exaggerated in the depressive episode, presenting with OC symptoms. One of my cases today has very specifically those symptoms. And surprisingly, in quite a few patients during the episode of mania, OC symptoms disappear. I don't know how to explain that, but it does disappear. So there is a lot of link between this OCD as a comorbidity. Another thing, one of the major points where I keep repeatedly talking about, when people say that antidepressant should not be given in the management of bipolar depression. I have one major point is that if there is a comorbid OCD, how do I treat comorbid OCD in bipolar disorder? How do I treat? Then people told me that go and give CBT. I don't know. That is where one of the big problems. Is there in any new drug, right, latest, as far as I know, sir, lurasidone, cariprazine is supposed to be one drug for bipolar depression. How common is BPD in children? If you take it below the age of 12 years, I think the incidence, I cannot give you the exact figures, but the incidence is less. But as you know that bipolar disorder, mood disorders, 40% below the age of 20 years is age of onset. I don't know who asked these questions, sir. Women and buying behavior. I know the answer, but I don't want to tell you, sir, about this. No, like this is something which is a little bit tricky about it. I am married for the last 3.5 decades, and then living very happily and peacefully, and then answering this question. I don't want to put my marriage into trouble. Like mental science examination. Okay, right. This is furnish the details of the cases. Definitely, I think I'm going to do that. I'll definitely do that. Treat algorithm. All right. Algorithm for rapid cycling, it's not really much of a difference. Not really much of a difference between algorithm for rapid cycling or in case of non-tolerance, what are the other medicines? Maybe later. When do we start a mood stabilizer? This is a very, very, very important question. Quite a few algorithms say that start in the first episode, but most of the times I say that this is one of the major problems in the management, and then we should not be doing that. Management of bipolar depression, this is the most controversial as on today in psychiatry. There are equally opposite about antidepressants and other drugs, the efficacy of it. And then if you look at some of these things, important strategies in the first episode and then depressive episodes, maybe we'll come to it later. Symptom analysis and management, okay, right. I think this question maybe later we should take up. It needs a little bit more discussion. Course of illness, okay, let's see that. How to manage treatment resistant case. Most of the time that's a problem. That's what I'm going to present today. Importance of family history, absolutely, sir. Importance of family history is very, very important. OCD, again, there's another question. Is it the journey of disease or diagnosis of bipolar? Two questions on that. Latest treatment update, I think lurasidone is one. Beyond that, there's nothing which has come. This is one case which is briefly asked. 37-year-old male, known case of bipolar disorder, recent episode, moderate depression, now presented with pregnancy. What is the drug you give? I think it's a very important thing which has come up here. Let's see that. No, like in a patient, known case of bipolar disorder, moderate depression. It's not severe depression. So severe depression, maybe I'll go for escitalopram. If it is moderate depression, I'll discuss with the family about whatever the little bit of teratogenicity with all the drugs. I would give it a try with RTMS, which is reasonably safer in moderate depression. The counseling part is definitely, if it doesn't work, relatively the risk of depression on the fetus compared to that, I'll go for escitalopram. But the escitalopram, suppose the patient gets a switch into mania, the one drug which I can say that reasonably I'll start is olanzapine. I will not start valproate, I will not start lamotrigine or lithium. Olanzapine is one drug which again comes to the category C. It's not absolutely safe, but reasonably. That's how I will treat the patient, but it has to be discussed very clearly with the family and also the obstetrician. Again, one more question. Treatment opinion for bipolar with OCD. There are 3 or 4 questions. What is the course of OCD? How do you manage comorbidity? What do you do with? I think this is a very, very important thing. Sometime we will take it up. Right. Bipolar features again with OC findings. One more. How do we resolve vague somatic symptoms rates? That is one thing which we all have the problem. How prevalent is bipolar disorder in young males? It's the same thing like. Second decade is the most commonly age of onset for bipolar. There are 2 peaks. One of the major peaks is in the second decade, starting from 15 to 25 years. Are there any markers to predict how long a depressive manic phase may exist? Absolutely. I think that's a fantastic question. I think sometime back in one of the previous presentations, I told very clearly, you have a patient with an episode of mania or depression, you treated that patient. After that, you have no clue. There's the same thing I told, no clue when the next episode is going to be, whether it is going to be mania or depression, when is it going to be, how severe it's going to be, what is the duration of it. We have no clue about it. If there is a marker, if there is some indication, that would be of great help. So these are some of the questions which have come. Now we will move on to the cases. There are three cases which I'm going to discuss today. Three different cases. I feel that that will be of some kind of an interest to you. This is the first patient. It's a male. I saw him first on April 2007. He's a graduate. When he presented to me, he was 23-year-old. The diagnosis is bipolar disorder 1, currently depressed. Reportedly, illness started 3 years before. So in the last 3 years, he is now 23, started at 20. He reportedly had 3 episodes of depression, 1 episode of mania. This is historically what the family tells me. He came to me 3 years after the illness. In those 3 years, he had 4 episodes, reportedly 3 depressions and 1 mania. So this is one of the classical, I think all of you know this Judd study in bipolar disorder. Even though mania is the signature episode, it's a depression where the morbidity is more, and classically for every episode of mania, there are 3 episodes of depression, 3 days duration. For every 1 day of mania, they spend 3 days in depression in bipolar 1. There's a family history. Father had a bipolar disorder and also alcohol dependence syndrome. This is some details about it, and he is depressed when he came to me. This is what he has presented with. So, young graduate, last 3 years is the illness, 4 episodes so far till he came to me. He presented to me in 2007 with depression. Diagnosis was fairly clear bipolar depression. There's no doubt. I didn't put any query here. So I straight away started the patient on valproate and escitalopram. That time, 2007, I used to believe much in valproate. There's no doubt about it. So I started immediately valproate. Escitalopram was not so much contraindicated antidepressant, so I started on that. And right, this is the life story of the patient. I treated him, he became all right, and then he disappeared. 2007, I saw him in April, treated him in this, and then reportedly maybe he became all right, and I did see him for 2 years. When he came back in August 2009, he said that, doctor, I was doing good. He finished his, like in a BTech, and he was, I think that time he was working somewhere, but later, all through this period till here, he was a software professional. He was working as a software professional. So when he came back in 2009 August, there were no medicines. He had come with a relapse, again depression. I started the patient on lithium and lamotrigine. So did I do right? 3 years of previous illness. He had 3 episodes of depression, again come with depression. So it looks like a predominantly depressive episodes. So I started him on lithium, the gold standard prophylaxis in bipolar disorders, and lamotrigine also I started because he already had 3 episodes. This is I feel that this is the best combination. I started him on that. So I started him on 900 plus 25. And then, right, here what happened is that when I started him on this, within about 20 days, he had switched to mania, which I call it as a switch. I have made some remarks also here. Switch because it is not a depression, which remission, and then 8 to 12 weeks of recovery, and then another episode is episode. If without that, if it directly comes to that within a month, it is called, we call it as a switch. So this boy directly from depression he has switched into mania. So because he is coming to mania, I started him on olanzapine. Right? Perfect. And I started increasing lamotrigine gradually to 200. So it's a 3 months period, 90%. And then because he has improved, I kept him on lithium plus lamotrigine, and olanzapine is gradually reduced. Right? And then he again disappeared. Because that's what usually happens when patients they improve, they just leave. Why do you say I have to continue the medicines? So here he discontinued for 2 years, and again here he discontinued for 1 year. He discontinued, and in 2010 September he came with a mania recurrence. I restarted him on lithium plus olanzapine, and then within he came in September. Within 2 months, 80%. 3 months, he has completely recovered, and I removed olanzapine. He is only on lithium. At this point of time, I told him, look, you are an engineer. You have been having it already for 5 years. You had almost 5 to 6 episodes. Every time you become all right, you are stopping the medicines, you are not continuing. This is not the way bipolar disorder is treated. You need to take the medicines regularly so that you will have a good prophylaxis. We will see our best so that you will not have future episodes. That is what is theoretically. I think Dr. Eastern has asked me some time back question that mood stabilization effective. It's a theoretically, why do you say that it's faulty? No, it's not faulty. Theoretically, it's perfect. You stopped medicine, you had depression. Again, you stopped medicine, you had mania. So you're not going to stop it. You have to take the medicines. So whatever psychoeducation is done, is put on lithium, olanzapine is recovered, and 90%. This is the serum levels. And then I continued lithium. Sir, right? So this is 2011. Then 2011, July, he had a depression, where I started him on escitalopram again. I do start antidepressants in case of bipolar disorder. I do not much hesitate. Whenever I feel that there's a requirement, I do start, sir. There's no doubt about it. Some of you may find it very faulty. There are a lot of literature saying that it should not be, but I do start. I do believe in this. Here, just let us go back, sir. Previous episodes, I don't know what happened. In this episode, when he came in 2009, I put him on lithium and lamotrigine. I didn't start antidepressant. Before I started antidepressant or thought about it, he relapsed into mania. It's a switch here. So here, without any antidepressant, the patient has gone into mania. If I had started antidepressant, you would have blamed me, said it's because of that he has become like that. Here, please, sir, please, spare some focused attention. This episode of depression, patient recovered only with lithium and lamotrigine. He came out of depression. No antidepressant, nothing. So we can take lithium as a good antidepressant in bipolar disorder. Can come to some kind of a conclusion, but may not be the thing, right? He again came with mania, started with olanzapine. Now, I'll go through one after the other. But if you see this, 2009 he stopped, again he stopped. From 2010, sir, you look at this. You look at this, sir. Down. He is an engineering graduate. He is very good. Once we started telling him that he is regular with his complaints. In the last, from 2010 to 2020, he has never stopped lithium. I have never stopped lithium. He is continuously on lithium from 2009 to from 2020, which was the last follow-up in March. Not a single visit was without lithium. And then if you took at the blood levels reasonably, sir, 0.58 here, 0.76 here, and then 0.69 here, 0.9 here. Some of them I have recorded, some of them I have not. So, a classical bipolar disorder. Before he came to me, it was a bipolar disorder. Clear-cut episodicity, with 2 years he was all right before when I treated him with this. Then clear-cut episode of mania, which no doubt about the diagnosis of bipolar disorder. One, patient is on lithium for 11 years or 10 years. Continuously, reasonably good therapeutic levels. This is in the range 900, 800. Usually I keep around 800, 900. Most of the times it is. What do I expect? What did I tell the patient here? You are stopping the medicines. You're irregular. Your compliance is poor. You're not taking the medicines regularly. That's why you are having the episodes. Now you take the medicines. I'm giving you the gold standard drug in bipolar disorder for prophylaxis. I'm giving lithium. So the patient believes me. I believe in the literature. I believe in the theory. I expect this whole picture to be mostly without any episodes, mostly without any recurrences. Mostly it would have been, if not 90%, 70, 80%, mostly it would have been, if theory goes. But it doesn't look like that. It doesn't look like. There's a mania here. There's a depression here. That's another mania. This boy went to Dubai. It's not like, and he got a job in Dubai. He said, can I go, doctor? Please go, no problem. Then he had a mania there. Then again, depression is switch. One more, depression switch, mania, depression. Admitted, it became a bit severe, and then I had to admit him. And the latest is this. So, the last 10 years, this many episodes, I'll count the episodes for you. At every time, sir, this is 900, 800, 900, 800. Never it was less than that. Never it was less than that. Now, the point is, at the end of, I am old. I've been practicing psychiatry for so many years. Now, after keeping the track of this for this years, and I continuing lithium, and now when I say that lithium or whatever is the prophylaxis, sometimes, at least in some patients, do not seem to be doing what they are supposed to be doing. If I say this, how does a youngster, a postgraduate, an early career psychiatrist who is in practice for only 4 or 5 years, how is he going to believe me? He read in the textbooks, he read in the journals that lithium is the gold standard. You give that, it's a prophylaxis, and then they're not going to have episodes, or the number of episodes are reduced, or whatever it is. Will he believe that, or will he believe me? I don't expect him to believe me, because he has not seen this. I have seen this. I have recorded this. How do I answer the patient when they come and ask me every time, doctor, I have been taking lithium, doctor. You told doctor, I have been taking lithium, doctor. It's a fairly good, doctor. Why did I have the episode, doctor? What's every time we say something and then try to justify. I think sometime back I asked you, if you continue to give a drug for such a long time without the so-called therapeutic response, what is the opinion of our non-psychiatrist medical colleagues about our pharmacotherapies? What do they think about us? What is this man doing? What is this man doing? Why is he giving lithium? All of us know that lithium, right, it's a problematic drug, but still, in spite of all this, even today I write lithium. I continue to write lithium because I don't have a choice. Lithium, if you continue the risk of hypothyroidism, after 25 years of continuous use of lithium, the renal toxicity risk goes up by 8 times. This boy has already finished a decade here. He's just 33. Another decade, his risk of renal toxicity is going to go up. And what is the benefit he got out of for his mood disorder? Sir, I am not trying to be pessimistic or criticizing this. I am only putting the facts, what I have seen. I'm only putting in front of you. Then some of you may say that, Dr. Reddy, this is one odd case. This is one odd case. There is one odd case. Based on one odd cases, you are coming to some judgments. No, sir. This is one representative case. That's it. This is not one odd case. There are umpteen cases like this. That is what my problem is. And somebody especially who takes the medicines regularly, if he's going continuously going on or like that, what would I do? Where will I go? What is the other choice? Some of you may suggest you should have started carbamazepine, oxcarbazepine, and then maybe valproate. I refuse to start, sir. None of them have that kind of an evidence what this drug has. And then second drug, third drug, fourth drug. I think sometime back I told you this mistaken kindness of a thing. No, there's no end. That's what I told you. Bipolar disorder, anybody raises any question, you are right. But what is the benefit? Now here, with this, now look at the clinical picture also. Let us look at. He had depression, straight away switched into mania. Then again, he came to mania. Mania recovered in about 3-4 weeks. I'll get you details later. Then depression. Depression, see here, 1 month. July he had, and then by August, he became all right. 90% improvement with lithium and escitalopram, right? Then he had in 2012 mania, olanzapine. He was putting on a lot of weight with olanzapine. I think around that time or something, I generally keep trying different drugs. So I tried him on asenapine. Okay, right, he was doing so. I continued asenapine. That is the time this boy has gone to Dubai. He was maintaining well, but in 13 January, he had a relapse. He was in Dubai. His brother came running to me saying that doctor, he had a problem there. So I quickly added olanzapine in spite of knowing that he puts on more weight. That is more confident on that. And at this point of time, I restarted lamotrigine. I started first, he discontinued. Again, I started, he discontinued. But then I came back to that because again, there's a depression switch is there. So here, he is on 2 drugs, lithium plus lamotrigine for 6 months. But then mania, and then again mania. But only thing positive here is that very quickly, January he is in mania, February he switched into depression. Then again, after about 8-9 months, then he got married here, 2016 mania, and then again within 2 months there's a switch. See the number of switches here. In spite of he being on these 2 drugs, one is lithium, one is lamotrigine. I think, yeah, if you notice here, this is one of the few patients where I increased the dose of lamotrigine to 400 milligrams, thinking that he has more number of depressions. So at least that will benefit. He was almost about 9 months or 10 months. It did not really benefit him. Again, I changed it to that. So all along, he was on lithium. For quite some time on lamotrigine. In between, escitalopram were there. So right now, latest was he developed some skin lesions. After that, I did not see him, which I felt possibly maybe a psoriasis. That is where for the first time I reduced the lithium dose, and then I have not seen him after that. Now, this is what the chronological thing which has happened for 10 years. This is the drugs I have given. This is lamotrigine. Lithium was there for 10 years. Now, this is the summary. Look at this. This patient was on lithium for more than almost about, as I told, the 10-11 years. Lamotrigine for about 4 years. Olanzapine in between, whenever there's mania, I used to. Escitalopram only twice. I think once I gave it here, right, for about 2-3 months. And after that, I didn't give escitalopram, only here I gave. Again, this was, but here I put it as 12 months because I was not knowing the follow-up. After 1 year, I didn't see him in between. So maybe I took it that he would have been continuing. So I didn't use this patient. You cannot question saying that is because you used escitalopram antidepressants more frequently, that is why more number of episodes. No, sir. Maximum maybe in the last 12 years, I used for about 6 to 12 months. So he was on this, right? Number of episodes. Before he came to me, he had 4 episodes. I told you very beginning, right? This is the one, no? 3 depressions and 1 mania in the 3 years before he came to me. After he came to me in the 11 years, he had 13 episodes. This is while on 2 drugs, lithium and lamotrigine. This is one of the not very typical cases. In bipolar disorder, generally you have 4 episodes in 10 years. Usually, that is a standard textbook description, but he has a significantly more number of episodes. There is something different about this boy is that every year he has been having 1 episode, like 13 episodes in 11 years, which is unusual. And this is before treatment, this is after treatment with two mood stabilizers. If you ask me, lithium and lamivudine in this particular patient has not done really any difference in the last 10 years. Then why were you continuing to give? I don't have a choice, sir. There's nothing else. And then I calculated what is the total duration of depressions. I know, like in this period. No, I'm sorry. Here I calculated now depression how long, mania how long, and again depression 90%, mania 90%. Like that I calculated. I'll be doing actually one thing. I think somebody suggested in the one of the questions. I think I missed. I think it's Dr. Tyagarajan from Vellore. I don't know whether it is the same Tyagarajan who was my colleague in CMC about 35 years back. He suggested that without knowing the cases, how do we ask questions? So what I thought I'll follow his advice. What I'll do is that after my presentation today, I'll take all your mail IDs, and this presentation I'll send you by mail. I wanted to go through these things in detail, like in a very at your leisure. What are the picture? Whether I did any of those mistakes in my giving the drugs and calculation of these things, whether there's anything. Next time we will have completely the discussion on these three cases. What can be done? What could be done? Because I also need your suggestions in managing this boy. Because at the end of this, I'm stuck with this with so many episodes. What do you suggest? How do you think we can make him at least for a brief period of 4-5 years episode free? Because at this point of time, he was all along, he was doing a software professional. He went even abroad also. At this point of time, there were 2 serious suicidal attempts in spite of he was being on lithium. The last suicide attempt was somewhere around this period, and the family said, you are not going to go anywhere. You are going to be with us. Resign your job. We'll start a business. That is where he resigned. Otherwise, he was been functioning fairly good. Right. What is the total duration of depressions in the last 10 years? 36 weeks. Right. Total depressions are 5 episodes. Manic episodes are 8. Total 13. Total duration of depressive episodes is 36 weeks. Total duration of mania is 40 weeks. Average depression was 7 weeks. Average mania is 5 weeks. It's like one of those textbook descriptions. Generally about depression is slightly longer. Mania is that 5 weeks, 7 weeks. But mania to depression is 1:3. No, here it's not like that. I was telling you, in a typical bipolar disorder course, for every 1 day patient spends in mania, he spends 3 days in depression. But here, the manias are more frequent. Manic episodes are more frequent. 40 weeks, 36 weeks. Mania, he spent more time. Right? Now I'll come to, and the switches. There are 4 switches. I think I sort of recorded here, switch and then switch. I'm going to send you the presentation. You can see it very, very detailedly whether now I missed something. There are 4 switches, and out of 4, 3 are from mania to depression. Few things, sir. There are 4 switches. 3 are from mania to depression. Patient was on lithium for 11 years. This patient, in spite of 11 years being with me, I gave him antidepressant at the most maybe about 6 to 12 months, not more. I cannot be accused of producing cycle acceleration or anything, right? This is very important here. Total duration of all episodes, 76 weeks, 36 plus 40, 76. What is the total duration of illness? 11 years, roughly about 550 weeks. From 2009 to 2020, when the boy was with me, taking treatment for bipolar disorders, which is supposed to be a continuous course of bipolar disorders, his illness episodes were only 15% of the time. 85% of the time, this boy was euthymic, functioning very well as a software professional, went abroad, got married. Because of the suicide attempt only, he was asked to resign. Now, this is what? Right? Now the sir. I'm not saying against this. For the sake of 15% of the time when he is ill, 85% of the time he was on so-called medications which are supposedly being called as mood stabilizers. Are we right? Right. Then the question can be, Dr. Reddy, if you had not given mood stabilizers, this would have been 50%. How long we keep on hearing to that kind of an argument? How long? It can. No. Even before that also it was the same. So here, the person was ill. The illness duration was about the symptomatic thing was 20%, 15%. 80% he was doing extremely good. And we are talking about mood stabilization, drugs, keeping on drugs 1, 2, 3, 4. I showed you one slide sometime back. The average number of drugs which are required is 7.6. Are we doing it right? Theoretically, it's fantastic. But practically, are we doing it right? I'll send you this slide, sir. This is one case. We'll move on to the second patient. This patient came to me in 2011, July. It's again bipolar depression, and then he's again the same drugs. This boy is supposed to have started 20, but there was some indication that it started a little bit early. Later, parents told me that doctor from the age of 15, he has been like this, and supposedly had one mania and one depression. Obsessive personality. He was referred to me by another colleague, mainly because colleague psychiatrist, because the bipolar depression it's resistant. I'm not able to get him out of the depression. It's a little bit difficult. Every time depressions are prolonged, it's becoming a problem, which is a problem really. Bipolar depression is a little bit prolonged, and then suicidal risk is always high. That is why the other psychiatrist has referred the patient to me. So again here, age of onset is now just 20 years. 1 plus 1 came to me in depression, sort of bipolar disorder. There's no doubt about the diagnosis. And this is the point he came to me. This is one of my very difficult patients. I need your suggestions in this patient. I need how to manage this patient because I've been struggling to get him out of it. Again, excellent, very brilliant boy. He did his engineering. Then he did his MTech. He was working for some time. Then he went abroad. He did his MS during the period of this illness. That is why I say that bipolar disorder, mood disorders are good prognosis disorders. He went abroad. He completed his MS. He came back in spite of so many episodes and all things which I'm going to describe. Right now, he doesn't have a job. He's struggling to get out of it. Now let us see that. Now this the whole history I could not fit in one slide. There are two slides. I'll just run through that. I'll just run through this, and then you can see it leisurely when I send it. Depression, I gave him. The previous patient, out of 11 years, I used escitalopram or antidepressant just for about 6 months. Look at this patient. How much of antidepressant I used? Depression, first episode, I remarked it. This is the first episode, and then second, like that, switch, rapid. I just put a remark so that you will easily understand that. Valproate, escitalopram, 12 weeks duration, he recovered, but he didn't recover with escitalopram. I started him on imipramine. Sir, a patient with a bipolar disorder, I start on tricyclics, which is a definite no. But he was referred to me because resistant bipolar depression already. So I have to do something to get him out of it. So I didn't have a choice. That's why I started. I may say that it's wrong, but still I say that I have started. And the patient became all right. And I quickly, and then he developed mania within 2 months. Right. All of you say that, okay, patient is an imipramine, and that is why he developed mania. Right. Whatever you say. Right. Then quetiapine. Then look at this. Episode of mania, first episode when he came to me, I started on quetiapine, 100 milligrams. Within, you see this, 6th of December, 21st of January, 80% recovery with quetiapine. It's one of the amazing stories. I don't have so much of belief in quetiapine, but this boy improved with quetiapine within. Why I am telling you is that lot of times The episodes in bipolar disorder, in this case, very clearly, one episode you recover with quetiapine, one episode with olanzapine, one episode with just like that they improve, and you don't know is it because of the drug they are improving or it's a natural course. It's sometimes it's so difficult. If if somebody tells me that somebody's mania has improved with 100 milligrams of quetiapine, I will not believe, sir. I will say that no, come on, man, it cannot be. But this is a fact staring at me. It's my own data. That's it. So now, even now, I don't believe. I think that may be a natural course. Right? He was drowsy, I removed. Depression. OC symptoms. That's why I said that beautifully. There are 3 or 4 questions today which I come to with OCD, OC symptoms, and then mania. I think it's wonderful. It has questions have come here. Premorbidly, OCPD disease. That could be the reason, right? OC symptoms have come, depression. I started him on escitalopram. And then within 3 months, it's a switch here. So it doesn't go through remission, 8 weeks of recovery, and then if it doesn't happen, it's a switch. Now, see, sir, beautifully this is rapid cycling. I'll tell you a fact. Till I made this chart, I've been seeing this boy for the last 10 years rather. Till I made this, we made this a few months back. Actually, let me tell you, I have been having the collecting the data since 2007. This data collection, simple spreadsheet is only for my own clinical understanding, so that like I keep forgetting what happened. So let me have the continuation so that what is happening to my patients. It's only that simple reason I collected this. There are some problems. I didn't do it very systematically because I'm not a research worker. After almost about 9-10 years later, I had 1 or 2 assistants who came to me who said that, Dr. Sir, there is a lot of data in this. It's good. Then I started looking into this. Then we started identifying patients. Then almost about 2-3 years back, we thought we'll pick up a few cases. We almost identified about 15-20 cases. We wanted to bring out a booklet. I don't know how many hours and how many days we spent on this data and some of these patients. Now we wrote and rewrote and rewrote, but unfortunately somehow I could not get it out into a book shape, because somewhere anything we do, I was not happy with the presentation. I was thinking that whether I am able to convey the same thing what I was thinking. So finally I thought, okay, let me present this to the group. So that is what is happening. So we have been doing this. So here I didn't know that it's a rapid cycler. You see here, 2011 July it started, depression. December mania, April 2012 depression, July 2012 mania, July 2011, July 2012, 1, 2, 3, 4 episodes. Somebody asked me, and how do you define rapid cycling? So this is it. 1 year period, if patient had 4 episodes, that is rapid cycling. This is a rapid cycler here. Right? Here, see, I removed valproate here and I started the patient on lamotrigine. The only explanation I can give is that it seems to be a case of resistant depression. Depressive episodes seem to be more. Lamotrigine is a better drug in the prevention of depressive episodes. That is why I started lamotrigine. Started escitalopram. This patient, I used all antidepressants. Now, like you'll be very angry with me for using all the kind of antidepressants, but I used all that. And antidepressants I used. From depression to mania. Sir, I want you to closely observe one thing. Here it's a mania, switch. Is a rapid cycle here with the 4 episodes. I started lamotrigine. He is on quetiapine. Deadly thing here. I do this, sir. This is not a random thing. I do it. Patient diagnosis mania. Escitalopram is still there. Patient is 40%. Patient is continuing to be in mania. Escitalopram is continuing to be there. What nonsense. Dr. MS Reddy, this is nonsense. You say the patient is in mania and you continue to give antidepressant escitalopram 10 milligram. I did that because this was a big problem here. I will be crucified for giving that, but still I do that because this came to me as a resistant depression. and the boy has longer duration of it. So I did it. Fine, I did it. But again, mind you, in spite of me continuing escitalopram 10 milligrams, this boy came out of mania. It took about 5 months, but he came out 90%. I didn't stop escitalopram, I continued escitalopram. Then he became 90%. So here is a patient who was a rapid cycler, who had a premorbid OCPD, depression with significant OC symptoms. When the patient went into mania, I continued escitalopram a small dose. Suppose you ask me, doctor, do you advise us to do that? No, I don't dare to. I don't dare to. I did that, but I leave it to your choice. I can't say that because there are so many implications for that. Now he got a job, and then he got into MTech, and I continued lamotrigine because it's predominantly depression, resistant depression at this dose. See here, after about a few months, significant OC symptoms, but I was not sure about the depression. So I continued. He lost his job here, but now okay, significant improvement, but there was a problem he lost. I continued this. Then again, 2014 February, again relapse of exacerbation of obsessive compulsive symptoms and a significant irritability, anger. I was not sure, but he didn't have a clear-cut depressive symptom. I put query, and then you see this. A patient, a bipolar disorder patient, a youngster who had a rapid cycling here, I increased the dose of escitalopram to 30-40 milligrams because of obsessive compulsive symptoms, possibly depression, and he recovered. Fortunately for me, maybe he recovered 80%. This is the time the boy wanted to go to Australia to do his MS. I said, go ahead. This go ahead, I say in mood disorders only. Go ahead, you have become all right, man. You can go and do. But only thing is somebody to monitor that. That's the only thing. He went to Australia, and after some time he came back. He's continuously, I reduced the dose of escitalopram. He continuously on this. This is what it is. He was doing that. He came for a holiday, and then he went back, and then up to here, if you see that, depression 1, 2 depressions, 2 manic episodes, rapid cycling. This is, I was not sure whether it is depression or not, but I continued lamotrigine. I gave dose of escitalopram and quetiapine. Quetiapine is all along on 300 milligrams. Quetiapine is also supposed to be FDA approved drug both for depression and also for long-term prophylaxis. So the boy was on 2 so-called prophylactic drugs, which are FDA approved drugs. Then he came into depression here. 2016, when he came back from Australia, he got into depression. It's a severe depression. This depression happened while on escitalopram. Escitalopram, quetiapine. Sir, please note, he had a relapse of severe depression while on lamotrigine 200, quetiapine 300, escitalopram 20. I had to admit him. I gave 5 ECTs, gave RTMS, not much of a change. Then went to desvenlafaxine, 150, 200, not really much, wondering whether something happened, MRA, brain and all, non-specific we did. Then again put him on imipramine, admitted him again and gave another 6 ECTs. So totally he had about 11 ECTs and tried with desvenlafaxine, didn't improve, 200 milligrams, then came to imipramine 150 milligrams. He improved here 80 milligrams, went back to Australia. Now I was looking at this. Why I had to give desvenlafaxine, imipramine and all those things. And at the end of it, when I looked at it, it's only 4 months. Now looking at it. Now why did I? Possible reason could be this boy came back. He had to go back to complete his MS. So parents were, all of us think that let him come out of depression as early as possible so that he can resume his studies. Maybe that this maybe sir, I was in a hurry. I wanted to try all that. Whether I overdid this, I don't know. But he was in severe depression. He went back. Then, right, he went back in June and October, he had a manic episode. This manic episode is severe in the sense, actually his manias were never severe. The problem is this boy was abroad. He spent a lot of money there. It's an equal amount of dollars he spent. it's quite a bit of a pressure on the family. The family was like blaming me like anything. Because of you, we sent him there. Because you said yes, we sent him there. This is the amount of money he has spent. I couldn't help it, but I had to swallow that. And then he came back. And here, yeah, right, here, depression, here, he was not improving with this. When I started the RTMS and all, this is where I started lithium. Then I removed lamotrigine. Why did I remove lamotrigine? He was on from 2012, right, 2012 to 4 years, he was on lamotrigine, 200 milligrams, a good dose. In spite of that, Corey depression, and again one more, I felt, what is there any point? Is it helping him? So I said, okay, let me go to my good old, now like it's gold standard. Till then, I have not given here because his manias are always brief. Depressions were very prolonged. So I thought, let me try with lamotrigine quetiapine. When it didn't work, I went back to lithium. At this point, I started. He had a mania while on lithium, but imipramine he was on that. I sort of know like imipramine induced, but maybe I don't say that, but possibly it's definitely. So quickly got him into that. Here, now like in October, November, he got into a depression switch and risperidone, urasidone, all things, and he became. Here again, depression, it continued for quite some time, this depression. November till June, he was almost about 6 months. Citalopram, modafinil, desvenlafaxine. Again, I was a little bit scared to give imipramine because this imipramine produced severe mania, whether he's going to have it. So always worried, but he's not improving. They didn't agree for ECT, so desvenlafaxine 200, all this combination. See that citalopram plus desvenlafaxine, these drugs. Finally, he switched into mania after about 7 months. By the time he completed, he was here, he had to do project work and all with the help of friends and all, he completed his MS. So because mania, lithium and risperidone, he recovered. Again, he went into depression. I was lost. He was on lamotrigine, he was on quetiapine. I gave him imipramine, desvenlafaxine, escitalopram, such a high doses because of OC symptoms, and then all this. At this point, I said that why don't you go to another center, go for an opinion. They said that, okay, bipolar disorder, they just started him on lurasidone and then sent. I really don't have so much of a belief in lurasidone, but still continued for some time. Didn't really, the lithium was 0.86, not much of a thing. So here, let me see that. All this episode, the same doctor, the same consultant who started on escitalopram, desvenlafaxine, imipramine and all that, now when it came to this depression, I said, let me hold. Because as a clinician, you're worried. Whether you're going to produce another switch, what is going to happen? See here, in this period, I didn't start him on any antidepressant because I was morbidly scared. What is going to happen? Once again, he goes into this, my God, what? Once again, it's this, what do I do? So I was holding myself. And lithium quetiapine, increase lithium to 1200. I didn't start antidepressant. Lurasidone, okay, after some time I stopped. It's not really working. So this is again how much time, sir? I'm sorry. 2018 January till 2019 February, where he had a switch to mania. This is almost 1 year. January 18 to, right, December 18, 2050, 2040. He is on lithium. Quetiapine, why it didn't increase? I think he was feeling drowsiness. That is the reason why it increased. I increased now lithium to 1200. So 1 year, this is the lithium level. Patient was in depression for 1 full year. 0.86 is the lithium. Antidepressants, I was, right. Somebody may ask, you gave so many antidepressants, why are you not giving? Yes, I understand, but it's a little bit of a worry. So I didn't start. Patient suffered from depression 1 full year. Then he became mania. This depression lasted for 58 weeks. I think here I even recorded. This depression was 16 weeks. Let me see. Yeah, the first one was 12 weeks. Then second depression, it's a switch. Then here I'm not sure about the query. And this third episode of depression, 16 weeks. And then there is fourth episode, switch again, right? And then this episode, 58 weeks. More than 1 year, this boy suffered from depression. I don't know. Relatives ask me. He comes and asks, like, okay, we'll see, we'll continue, we'll continue, we'll continue. Then, right, he switched into mania. He developed mania here. Started risperidone. Manias always like he recovers. See here, May, and then by July he became 80%. Manias are always like managed. Again he got into depression. He lost his job. Right now, currently he is in mania. Lithium level is this. Quetiapine, this one. Risperidone. I'm sure he'll come out of mania. There is no problem. He'll come out of mania. Manias are never a problem, but depressions are a problem. See the kind of number one, lamotrigine for quite significant amount of time. I'll run through this. 9 years, 13 episodes. Again, one of the different cases. Classically, it is supposed to be 4 episodes in 10 years. 13 episodes this boy had. He was on lithium for 4 years. At one point, 1200 milligrams. Lamotrigine for 4 years. Quetiapine for 4 years. Good so-called prophylactic drugs, FDA-approved drugs. But escitalopram I gave him for 4 years because of depression-related things. And I gave all sorts of antidepressants, escitalopram, desvenlafaxine, imipramine, risperidone, and for some time for this manias. Look at this. First episode, depression, 12 weeks. Second episode, 12 weeks. Third episode, 16 weeks. Fourth episode, 28 weeks. Fifth episode, 58 weeks. If it has stopped here, I would have been finished off. Because it is because of you are giving imipramine, desvenlafaxine, all those things. You remember yesterday I was talking about acid. You remember I was talking about tardive dysphoria. Because of all these drugs, he became like that. But fortunately for me, 6th episode, 8 weeks. But this is the picture what we see. Why this is 58 weeks, why this is 8 weeks. A lot of times in bipolar disorder, we just don't know, sir. We find it very difficult to understand what exactly happens. Is very, very difficult. Manias, all along you see 6, 12, 6, 6, 4, 8. That's it, current episode mania. Now, I did the same calculation what I did before. Total duration of depressive episodes is 134 weeks. Average depression lasted 22 weeks, which is quite long, 5 months. Here, total duration of manias are 42 weeks. 6, it's about 7 weeks. So here, if you look at this, mania is 42 weeks. Here, 134 weeks. It's exactly textbook description of 1 episode of mania, 3 episodes, 3 duration. It becomes 1:3 perfectly. Now, totally, how long he was episodically? 176 weeks. And what is the total duration? 468. 30, in spite of that severe illness, it's only he is not well 37% of the time. 5 switches, 4 depression to mania, 2 while on ECT, 2 on quetiapine. I think we also have to understand. I showed you lamotrigine, quetiapine, and then he had a switch. You can't blame all the time this. One is from mania to depression. This is what it is. Right now, he is in mania. This is the number of episodes he had. He was on lithium for this amount of time, this amount of time. What should I do next? These 2 boys, if you can suggest me to give some drug which can prevent the future episode, you have made their life. Both of them are very well educated, brilliant boys. Both of them are, one is is a postgraduate. If we can somehow give them a respite for about 4-5 years with any drug or any kind of intervention you give with no episodes, if the second boy, if we can get him out of these depressions for at least 5 years, he will get into a job, he will settle down, he get married, and he will do very well. The first boy also, if you can cut down, that's also, this is 13 episodes, that's also almost about how many episodes? Right, again 13 episodes. Here, the manias, here the episodes are very, very short. Just about the average is, 5 5 weeks and 7 weeks. Here, the episodes are like an average episode is almost about, this is average depression is right, 22 weeks. It's 7 weeks. So much of a difference. But at the end of the day, it's only this person. So I'm going to send these 2 cases to you. I need your suggestions where, how we can see that they will not have the next episodes, at least for the next 4-5 years, 3-4 years. This is what I keep telling, that acute episode, we are doing a fantastic job in cutting down the duration and reducing the morbidity. When it comes to prophylaxis, I have been telling repeatedly, umpteen number of times, we seem to be failing miserably in prevention of next episode. We seem to be failing miserably. These are the examples which I want. These are not one-odd cases, sir. No. If you say that, Dr. Reddy, this is 1 in 1,000 case you are present. No, sir. These are fairly frequent. Once we document, we'll realize that. Now, we'll go to the next case. This boy, again, age of onset is 22. This is again another thing I say, that psychiatric morbidity, especially mood disorder, starts in around the 2nd decade. How long do we give prophylaxis? 5 decades, 6 decades? How many decades? What is the problem? How long do we do that? And are they useful? That's the only thing. Supposedly started 22. He came to me when he was 30. And in 2014, when he came to me, probably the previous diagnosis was schizophrenia. I do not know. He was on haloperidol 5 milligrams. The poor chap had tardive dyskinesia, orofacial movements and lingual movements, very clearly. One friend brought this patient to me saying that, sir, he has got these problems and all. He has been taking treatment from somewhere. And then age of onset is almost about 8 years course of illness. There's a family history. Past diagnosis possible, I don't know. When he came to me on this. Now, this 8 years, I have written here on and off. I was not very sure. This is, if you look at my data, there are a few areas which are the major weak spots in my data sheet. One of this is this on and off thing. People laughing at me saying that this is your major Achilles heel. The problem, sir, the problem is the previous patient, I said 3 episodes, 1 episode. In the day-to-day clinical practice, half the time you don't get the clear history from the relatives. Sir, ऐसा होता है, ऐसा कभी होता है, कभी नहीं होता है. You try for some time. When you are not very sure that it is continuous or not very definite it's episodic, I'll just put it there on and off, which for somebody like you who comes and looks at it, looks nonsense. What is he writing on and off? But that is my weakness. When it is on and off, I'll keep it open. At least I don't say that it's a continuous illness. That's the only reason, nothing else, because time factor is fun. I'm basically not into research. So on and off, whatever it is, he has got tardive dyskinesia. This is the picture. He came to me, he was brought by a friend. So obviously, all of you would have done this. Haloperidol immediately I replaced olanzapine. So fortunately for him, this is an early, maybe reversible tardive dyskinesia, early case. Within about 3-4 months, he completely came out of tardive and he is also all right. Olanzapine is my favorite drug. Unless somebody produces tons and tons of weight, I keep them on olanzapine. I was not sure about the diagnosis also. So within 3 months or 4 months, he developed depression. Clear-cut, definite depression. Till then, I was not sure about the diagnosis. So here, I don't know why I started quetiapine. I'm not very sure, sir. Usually, I start on antidepressants, but I don't know. God knows what is the reason. Continued olanzapine and started quetiapine. And then in a month, I increased it to 400. Maybe, see, one of the problems is that I do a lot of trial and experimentation in my clinical practice. When a new drug comes, I try the drug very regularly, very aggressively. I want to know what the drug does. I want to know what is the benefit of it. I want to know whether it is really working. I want to know it myself. I do it. Maybe that time, see, sometimes, some of my colleague psychiatrists ask me, what is this one period? All these drugs are there. One period, at that time I thought, okay, let me try this drug. Maybe that's the reason. I tried quetiapine. 400. Beautifully has improved. See, May he came with depression. By July, 90%. So This patient who is later bipolar depression on a combination of olanzapine here, because after 1 month also he was continuing like this, I started on lithium. Lithium and quetiapine, perfect textbook. Bipolar depression, 2 drugs, lithium is quetiapine, but I didn't look at it on that perfect angle. Maybe I would have, thinking about experimenting with quetiapine, but I started lithium. 2 months, 2015 May, 2015 July, he became 90%. Lithium and quetiapine, 800, 400. Now, after seeing this depression, looking at the history, I was reasonably certain this is possibly a bipolar disorder, not schizophrenia. So tardive anyway is gone. Anyway, I don't start and continue haloperidol, I don't write. Lithium and quetiapine, boy is doing good, perfect, continued. Continued, he got a job, fantastic, continued. It's around, usually it's around that range, 800, 900, I maintain it's in that range. After 2 years of lithium, this guy, I routinely keep doing once in 6 months, lithium, thyroid and creatinine, one of the standard things. His TSH was 9. This is the first kind of a red flag. Otherwise, I would not have bothered. Standard, I will even tell, if suppose one of you ask me that a patient well controlled on lithium, suppose he becomes hypothyroid, are you going to stop lithium or treat him with Tylenol? I'll say treat with Tylenol. Don't stop lithium if the lithium is so much beneficial. But here, I have not seen any manic episode in the 2 years. Then I thought, let me, again, sir, let me give it a try. It's not strictly followed. Some other case, maybe I would not have done. I said, let me see. I reduced lithium to 400. Right? So after 4 months, it is 0.4 below the therapeutic levels. TSH has come down to 6. Beautiful. Right? Then I made it 300. This is actually a nonsense. Some of you will say nonsense. We do not have any extended release preparations of 300. We have only twice a day. I gave him once a day. I do that. Sometimes some of you may criticize that just to see. Anyway, he's on a subtherapeutic dose, give it. So for almost about October 2007 to July 2018, he was on subtherapeutic dose of lithium. 1 year. I was wondering whether he may have a mania. My God, if he's going to have a mania, I'm going to feel guilty. If he's going to have a mania, fortunately, he didn't have. And luckily, thyroid thing, it has come down. At least I did something good for him. So after all this experimentation with 400 and then 300, I said, stop it. Let me see. I do that, sir. All the criticism can be there. If you stop it, lithium, it doesn't work with the same, all those things, but I do that. I stopped it. When? October 2018, I stopped it. And then February, 1 year he was all right. February 2020, he had a relapse of mania. I didn't restart lithium. I just started, I am not starting lithium for acute mania. I started on risperidone, continued quetiapine. Just in a period of 1 month, not even 1 month, I think 3 weeks, he became all right. This is the latest. This is a video follow-up. He's all right. I stopped risperidone. Quetiapine is on 600. So 2014 to 2020, this boy, tardive dyskinesia gone. He had 1 episode of depression, 1 episode of mania. He was on quetiapine continuously, lithium for this length of time. And right now he is only on quetiapine. Right? This boy. And this period, now I stopped lithium. I don't know what's going to happen. So 2015 to 2017, 2 years, he was on good dose of lithium. Nothing happened. 17 to, I started reducing 17 to 20, no lithium, but still no relapse. That's the important thing. Virtually no lithium, but still no relapse. So now, I'm sorry. Let us look at this picture. Here, I don't know whether you are able to see this. 1 depression, 1 mania, depression duration of episodes, and then duration of total episodes. If you look at, this is virtually, here he had about 2 months. This is 1 month, totally period of 3 months. That is 12 weeks. From 2014 to 2020, this boy had a morbidity of one depression, one mania, which lasted for just 12 weeks. You have seen this. And duration of illness is 6 years, which comes to almost about 300 weeks. 12 weeks he was not well in a total period of 300 weeks. Do we continue so-called prophylaxis here? Is the question there. I'll leave it to you. I'll leave it to you what it is like that. What do you want me to do here? He has been taking fairly regularly. I stopped lithium purposefully. And then what is the prophylactic effect of this and this? And then what do we do in future? The same kind of a thing. You have seen two previous cases, which I struggled. Here, it's less, you just walk through this. This boy is all right. Now, maybe I'll take another 5 minutes. Whatever I say, whatever we say, this is the foundation. There can be some variation in this. We clinicians listen to evidence-based medicine with respect. We look for the evidence which is trustable, dependable. This trustable evidence is what I took from the Cochrane database, reading that. These are three different things for your evidence-based medicine: RCTs, naturalistic studies, and case series. RCTs are level 5, evidence level 5, case series are level, RCTs are level 1, case series are level 5. Understandable. Because now, like case series, individual case series, sometimes it's very, very difficult. RCTs has given all this. This is naturalistic studies, what STAR D and STEP BD, which are case series, is something which I have been talking about. It's a level 5 evidence, right? I don't have any authority or right to question anybody because I don't do any research. I have not published any papers. I don't do any research. But only thing is, I raise questions, which we all have to raise questions. Why this in this third patient? There are only 2 episodes in the last 6 years, which was only for about 2 months is depression, 1 month is mania in this bipolar disorder. Why this was totally different in 13 episodes in the other patient? Are there any indications in the beginning, any kind of an indication which you get, any medication which can prevent that? That is where when Baldessarini says that more than 2/3 of bipolar patients, the course is random and chaotic. These are the same words he uses. When he used a follow-up, 6 years follow-up, 1/3 only follow your pattern, 2/3 is random and chaotic. But is random and chaotic, how do we continuously administer prophylaxis? On what basis? On this platform, I'm standing here and then able to talk to you. It's only because of this, nothing else. Otherwise, I don't have any right. I'm not a research psychiatrist, but I'm a clinician. A clinician which every day sees the patient go through his frustrations every time the patient, while on lithium, while on lamotrigine, while on 3 drugs, lithium, lamotrigine, quetiapine, he comes to me with a severe depression. I just don't know what to do. On lithium, quetiapine, and then like lamotrigine, he comes with relapse of like a recurrence of mania. I don't know what to do. How do I manage? How do I do that? How long do I continue? That is the problem. And I'm not only a clinical psychiatrist, I translate the research, what the research has given, translate that into the clinical practice. When somebody says Lorazepam is a good drug for bipolar depression, I try to translate into the clinical practice and see whether it really works. When somebody said escitalopram is a good antidepressant, I tried to translate and I found that it's a good antidepressant. When somebody said tynaptin is a good antidepressant, I tried to translate, but I could not find and then throw it. I'm a translational psychiatrist. And in the process, I also do advocacy. We all are advocacy. We all do advocacy, which is very, very, very important in every branch of medicine, especially in psychiatry. Whatever the research work, see, let us take a simple example. Fluoxetine has come here. It was tricyclics. It has come from the research, fluoxetine, SSRI. As a clinician, I used it. As a translational, I translated that into that and found that it works as a good antidepressant. And what is it getting translated? Depression is treatable. There are good drugs available for the management of depression. Episode is curable. Don't worry about your depression. There are drugs which can cure this. You become all right. This is how the advocacy goes. And you treat more patients, more and more patients come back, more awareness, stigma gets less, more treatment spread, reaching the last mile. That is what happens. Without that, it doesn't happen. This is what we do it. So what I say is that we have been listening to you, evidence-based medicine. Now I think evidence-based medicine, time has come. You listen to clinicians for your future guidance. You better listen. Evidence-based medicine, you have to listen to the clinicians for the feedback, and then what is happening, that I think you have to listen to that. Now this is the last slide. I'm raising a lot of questions, and with that I'll stop today. And then I want you to look at all this, because I'm going to mail you the entire PPT. Look at the 3 cases, give me suggestions, let us discuss about next time. And also here I'm raising few questions. This is the most important thing. Hundreds of times I say that psychiatric morbidity begins in second decade. Somebody was asking about step BD. See sir, step BD selected as an antidepressant bupropion. Why did they select bupropion? We all knew tricyclics. That was the group which we are using. After tricyclics, the drugs which are coming to is SSRIs. Why did they not use SSRI? Yes, they used paroxetine, but why this NDRI? 2018, there is a meta-analysis. If any of you want, I can send that, where they say that bupropion is found to be a weak antidepressant compared to almost all the antidepressants. So you try with a weak antidepressant and say antidepressants are not effective. Right, why? Right, study. Initially, when the recruitment, they said they are not going to take patients whose HAMD is less than 14. But later they have included 600 patients who are less than 14. I don't know why. What is the reason? And then the measurement metrics, they were supposed to be using HAMD. But half the way they removed HAMD and then used QID. One of the reasons is that HAMD is not giving sufficient kind of remissions. Is it if something comes like that, where will our science go? Attrition. Study started with 4,200 patients. At the end of 1 year, there was 130. What happened to those patients? Why they were left out? We need to know. HAMD 17. I think most of you know this. I feel that whenever I read it, I feel, my God, what is happening? How can this be so silly? For an antidepressant to prove that it is an antidepressant compared to placebo, according to NICE guideline, there has to be a difference of only 3 points. Only 3 points between a difference between a placebo and antidepressant. I don't know, but I don't look at 3 points. I look at 30-point difference if the antidepressant has to be effective, and I'm seeing that. And then this is where Erwin Kurtz criticized that even these 3 points are not there. Most of the antidepressants in the literature is 1.6 or 1.7. Sir, we all use valproate left, right, and center, whatever form. I'm not talking about epilepsy, for a bipolar disorder. You use it for mania, you use it for depression, you use it for prophylaxis. And this is supposed to be the range, 50 to 100 micrograms per ml for use in BPDs. Where is the evidence, sir? Maybe next time, let's see that if any of you get me a paper where saying that this is the study which has been done and in bipolar disorder, and this based on that, we are coming into this conclusion. I'm going to ask much more harder question, much more difficult question. Maybe some of you may be angry with me. Lithium therapeutic range is 0.4 to 1.2. Where is the evidence? Who has given us the evidence? Is there any paper which compared the values, arms, 0.2 to 0.4, 0.4 to 0.6, 0.6 to 0.8 or 0.9, 0.8 to 1, 1 to 1.2. There are 4 arms, 5 arms. Out of these 4 or 5 arms, these 2 arms, it is more therapeutically effective, and these arms, it is not. Is there any paper based on which we are following this? based on which we are doing the sample. If we give the once a day lithium preparation, it is supposed to be at the end of 12-hour sample at the trough levels. If we are giving a once a day sample, once a day dose, what time you are supposed to be doing it? 12 hours or 24 hours? Right, I agree. There are a lot of literature. But lithium overdose is it's very difficult. Every depressed patient, I look at him as overdose risk. How do I give lithium? Right. People say that lithium is an orphan. ECT is one of the best treatment in depression. There's no funding. Why NMH? No, that's what I said. That who are you to ask questions like that? You say that. But how much of no, funds NIMH is giving for research on ECT and lithium? What is this concept of mood stabilization? I've shown you two, like in cases, decades. Generally, the episode starts in second decade, and for 5 decades or 6 decades, you have to give so-called prophylactic drugs, which are not that easy drugs. Fortunately, we are not looking at the bipolar disorder 3, 3.5, 4, and all those things. I did talk about some time back, bipolar disorder 2 is a myth. ICD-10 did not have the category of bipolar disorder 2. But ICD-11 came with that. ICD-11, hypomania, diagnostic criteria, duration, they talk about several days. Several days means how many days? Whose several days is this? It has to be 2 or 4 or 8 or so. Why people come out with this kind of a vagueness in their diagnostic? ICD-11, the brand new which has come, hypomania duration is several days. So like this, there are so many things. This FDA black box warning, what is it doing? How much of harm it is doing to all our patients with the depression? How much of harm it is doing? Is it doing any benefit? Everybody Googles now. Everybody who Googles, who looks at this. Most of the time, as I told, that it's in adolescence mood disorder start. An adolescent teenager is brought to you by his parent. When a parent brings the patient to you for depression and you give antidepressant and the parent goes back and looks at this and looks at the suicidality, do you think the parent is going to give the child the antidepressant when they look at this? Increased suicidality with fluoxetine in adolescents, especially when they say that. Are we doing anything? Yes, it's a fact, but is this fact to be not like published like that without, what is the use of it? We have to look at. Last time also said that, is there any way we can throw out this warning? What purpose it is serving? Not like that. These are the questions what we ask. Yes, facts have to be known, but is the fact to the benefit of the patient or doctor or individual, or is it going to be doing more harm and then more kind of a panic situation, more kind of a negative attitude is it going to create? That is what is the problems. And recently there is something like placebo response is increasing in the recent decades. Why? I think we have to do one topic on placebo. I think it's long overdue. Why is placebo response increasing in recent decades? What are the reasons? So why bupropion? Why they include all this? Is it 3-point difference are we looking at? Where is the evidence? Where is the evidence? Which paper shows us clearly this is effective and the other way? I know more than that it is toxic, but less than that where it is. And then what about the overdosage risk? Whatever you talk, I am the clinician. You say that I am the clinician who is giving lithium to that. If that man goes back and takes 10 tablets of lithium, I am scared. He takes 20 tablets, 100 tablets of escitalopram, I am not bothered. No fatality with escitalopram, no fatality with fluoxetine, no fatality with sertraline. Maybe I think 1 or 2 cases reported with paroxetine. Every depression patient suicidal risk. And then, no, nothing happens. Nothing happens, but right, it's a problem. ECT. The whole of the Western world do not give ECT and they talk about so much about resistant depressions. And then we have to, and then what is the several days? How can a scientific diagnostic criteria, right? Does it serve any purpose? Any purpose? Any purpose? Depression, suicidal ideation is the classical symptom of depression, like chills in malaria. And then you say that the only treatment what we have is antidepressant. And you say that it increases. Last time also I said, I think we clinicians have to seriously, what can we do, right? It's not that we can do something about it, but we have to seriously think about it. And all the time my worry is this and this and this. Suppose it starts in the fourth decade, fifth decade, you are not worried, it's not that. See this. You are dealing with this. Your medication, the three patients, one is 22, one is 20, other is 23 years starting. And these boys are suffering. And we talk about prophylaxis. One is doing fantastically well. Out of 5 years or 6 years, he had only 12, no, 12 weeks of illness. Otherwise, he's doing absolutely great. The other boy who is brilliant, who has done his MS, is suffering. We don't have tools. Give me some drug which is a good prophylaxis so that I can prevent the next episode for those two boys. We'll make their lives. So these are the questions which we have to think about long-term treatment. Short-term, fine, we can do anything. But when it comes to the long-term treatment, we have to think about all those things. And then, right, I think maybe I'll stop it here. There are some questions also, but at the same time, I'm going to see, as I told you that I'll collect all your mail IDs and I'm going to, mail this presentation. Please, whenever you have some free time, run through that. Please don't hesitate to point out whether I have done somewhere some kind of a mistake in my managing that, because nothing is perfect here. I know that. And anything further can be done, especially for those two boys. And then what is the pattern like? Why the pattern is varying? All those things, if it can be done, it's going to be very good. And then there are actually quite a few questions here. Do we take it up? There are quite a lot. It's already 10 o'clock. Right. Rapid cycling, 4 cycles to be many. It need not be. Yeah, right. I think let me quickly run through this. 4 cycles. It can be mania, or 4 men, but it's not easy. Rapid cycling, unless there is a switch, it's impossible to diagnose, sir. Right. If you take depression, 2 weeks for a diagnosis, and then after remission, it has to be at least 8 weeks to say it's a recovery. So 8 to 2, 10 is already gone. You have only 2 weeks left. If it is to be 4 episodes, it's very difficult to diagnose. Very difficult. But this patient, he had one because he has switched directly from depression to mania. More common mania or depression after postpartum? Can't really say that. A lot of times it presents with depression and it depends on the previous episode. Mostly we see depressions.
Doctor, can I ask you a question?
Yeah, please. Now,
I'm Dr. Murali from Bangalore.
Yes.
Damaya Medical College.
Yes.
Why we should look at all the evidence-based medicine studies for all these things? Because ours is a country where we all practice with our experience. We do not really have any guidelines as NICE or WHO or ICMR. And most of the time, patients do recover with the person's experience of utilizing whichever medicine is better for them. For example, one simple example is that fluoxamine dosage. You can go for increasing beyond a particular limit. NICE does not agree for that. What is your opinion on this?
See, here there is only one thing, sir. I think, I don't know why I put that slide today and then your question came. The last but one slide. Evidence-based medicine is something which is science we have to follow because you are perfect. You are a good clinician. You are a decent clinician. You are a perfect, you follow certain guidelines, but everybody need not be. I'll tell you an example. Long time back. Now, I can never forget that. I was sharing a session somewhere in Bangalore only, the management of something like a mood disorder, MDD. The speaker went on to stage and did that first stage. In my practice, I know like it's a combination of amyneptine and then amoxapine and then like an imipramine at small dose is the best thing which works for me. I don't think, sir. That does not. But at the same time, evidence. That's why I said that evidence-based medicine, we have to look at trustable evidence. I agree with you. I agree with you, escitalopram. Riboxtin, I don't agree.
Yeah.
But also we have to justify that. Suppose you say that we don't have to follow evidence-based, clinician can do whatever he wants. We are going to throw into chaos.
Right. That's what point I wanted to make is that
Yes.
clinicians should do the best as a clinician,
Yes.
not following the guidelines from the government.
Yeah, it's like maybe I'll try to put it in a slightly different way. See, like we have to follow the traffic rules, but at the same time, we have to find our way how we drive ourselves. But no, like some way, some rules have to be followed. That's the only thing I say, sir.
I think you are true. Thank you.
You're right. Twice just escaped from fulfilling the criteria. Rapid cycling, we don't have to worry, sir. Rapid cycling is only a phenomenon which is seen only transient. A rapid cycler once does not mean that he's going to be a rapid cycler for lifelong. No, no, no. We have seen our own patient itself. And what exactly it matters, at some point of time, they were telling that valproate is a better drug. Now there's really not much of an evidence. Bipolar 2, it is supposed to be more. Females, it's supposed to be more. I don't give really much of an importance to that. Findings are, this is the only thing. This is only my loud thinking. This is only sharing some of my experiences with you, which some of you also may be experiencing. That is the only thing, nothing else. So very frustrating. Exactly. This is the same sentence. Every day I sit in my chair and then I uneasily keep moving when the patient like this comes back and says that, doctor, I'm again having it. Where do I go? What do I say? And then somebody says that, no, start on mood stabilization, which makes me feel very angry. So-called mood stabilization, which is a nonsense, and started from the first episode is another nonsense. And people criticize Indian psychiatrists saying that you people don't use. We are doing it right. We are clinicians. We are not armchair psychiatrists sitting in the universities. You don't see your patients continuously for years. You see for 2 months and then your nurse practitioner sees the patient for another 5 episodes. Study what happened. They have recruited. Every 2 weeks, it's an IVRS, not on the patient. Only once in 2 months they used to see. So when you put guidelines like that with that kind of a thing, it's a little bit of a problem. When somebody says lamotrigine is useful in the management of acute depression, I find it extremely difficult to sort of accept that evidence. And then inevitable mood swings natural to this disorder. No, without the magical drugs which we need. Last 2 years, I'm finding maintenance, aripiprazole a little bit more comfortable. Whichever drug, sir, whichever drug, not a problem. But aripiprazole, at some point of time, theoretically again, aripiprazole is a fantastic drug. You look at the receptor profile, you don't find any drug better than that. But when it gets translated into that, is it going to be? Because that's where I say that in bipolar disorder, what we require right now is long-term studies, crossover studies. A patient, when he came to me last 10 years, he had 8 episodes. He came to me. I started him on lithium. Compliance is good. Next 10 years, if he has got 3 episodes or 4 episodes, then I believe that and then stop it. And that kind of a crossover studies, because you have seen this. One patient in 5 years, he had only 12 weeks of morbidity. The other patient in 10 years, he has got 130 weeks of morbidity. And then these two patients are in one of these trials. We will not get right. 13 episodes in 11 years. Whether it is due to treatment failure, poor compliance, no, sir. Both these patients' compliance is good. That much I can say. Very low dose of drugs. Then we have to say that lithium I have been maintaining at 800, 900 with a reasonably good therapeutic levels. Lamotrigine is 200, is a very well accepted thing. Then where is the low dose? Quetiapine 300 is a well accepted. Where is the low dosage? That is what we need to look at. There is definitely scope to increase lithium. Lithium, I did increase in one patient, 1200, significant tremors. And then high dose of lithium, higher therapeutic levels are always linked to higher renal toxicity. And then even that I'll buy. If you say that, okay, keeping the patient on 1 milliequivalent of lithium is going to give a definite therapeutic prophylaxis, I do take it, but I don't think. Then valproate, lithium plus valproate can be tried. Yes, sir. I know, I told you. Somebody will say carbamazepine, oxcarbazepine, valproate. Sir, between you and me, I think almost about 8-9 years back, I did a debate with one of my esteemed colleagues. I was favoring valproate. The other doctor was favoring lithium. Somehow I could carry the day saying that this reason valproate is. Today, if you ask me, no, sir. I've stopped writing valproate because I don't believe that this drug is working at all. There is enough evidence that valproate is not useful for, I'm sorry, for anything in bipolar disorder. Don't get angry with me. At least I have one data to support. I think last time also I told the Pharmacopic Vigilance Commission of European Pharmacopoeia, I think 2 years back or 3 years back, prohibited using valproate in every childbearing age woman except for epilepsy. Bipolar disorder, they said that 3 indications. One is epilepsy, second is bipolar disorder, 3 is migraine. They allowed it for only for epilepsy. The other 2, they said that there's not enough evidence to say that valproate can be used. It is, you cannot use, according to the European, like in pharmacopoeic guidelines, that valproate in a childbearing age of a female for bipolar disorder. That shows that there is not much. There is no data. It's not FDA approved drug. Even if you take that, it's not FDA approved drug for prophylaxis or long-term treatment in bipolar disorder. That is where the concept of mood stabilization has done. See, right, you use that and then use that and then use one more. There is no end, sir. That's where the problem. But let us see that if you suggest that this is going to be definitely useful, the point is there are no fixed ideas like this. I started with valproate, using valproate left, right, and center over a period of time, seeing this. Today, if you are, I asked you one question, sir. What is your where are the papers? You tell me that this is the effective dose of therapeutic range of lithium. You don't have. It's like arbitrary we are doing it. Okay, sometime point, science cannot continue like that for some time. It is science is medicine is approximate science. Medicine is never perfect science. It's approximate science. We all agree, but we can't go on. See, I told you, if any of the physician, any of your friend sees my slide saying that 11 years this man has been using this drug lithium, and the patient is going on having manias and depressions like that, what is the purpose of using this? What do I answer? That's what I want. Why are we continuing? Yes, I think I answered that question. Generally, it is not. But I do that a little bit of a thing. But there I gave a reason because the patient was one of the cases of resistant depression in bipolar. It took a long time. There's a OCPD, significant obsessive compulsive symptoms were there. So in spite of that, I took a risk and then gave escitalopram. I did. But in spite of 40 milligrams, he didn't relapse into mania. I think I showed you last 3 trials where the switch into mania at the end of 25 years with a family history of bipolar disorder is only 20-25%. So not to be so much worried about it. What about exacerbation of OC features with antipsychotic? Which antipsychotic? See, one antipsychotic, if you ask me, clozapine is one really problematic drug. They say that olanzapine also, the best drug with OCD antipsychotic is supposed to be risperidone, but still no, like I don't know much, but I use olanzapine once in a while. What will be the most preferred anti-obsessive drug in bipolar? I use escitalopram, sir. There you can again find fault with me. For you, citalopram seems to be a jinda talisman, but still I say that use it because there are so many positive things. I use citalopram. I don't use much of fluoxamine because there are enough reasons. Amisulpride, I don't use much, sir. Aripiprazole, I do use, but not so frequently because, akathisia is one problem. That's one thing, nothing much. And psychosis, yeah, OC with psychosis is different. OC with bipolar is different. OCD with schizophrenia, it's up to you. You can do anything you want. But here it's a seasonal variation, right? It can be there. Fluoxamine is relatively safe. Definitely, I don't agree, sir. Switch, I don't know, but fluoxamine usefulness, I'm not very confident about it. Why did you change to olanzapine when the patient is stable for 1 year and quetiapine? Maybe if at all, I look into that. You also please look into that. One of the reasons could be initial period patients tolerate quetiapine high doses, but once they become all right, they start complaining of more and more drowsiness. I think that is the reason. Maybe that's the only thing, nothing else. Or sometimes they say, doctor, it's very costly, sir. I don't want to. Maybe that's the thing. Role of lamotrigine mania, 0. Valproate and then clozapine, yes, right. Valproate, definitely no. Clozapine, okay, I agree with that. But clozapine, second patient, there were significant obsessive compulsive symptoms for an extended period of time. I just now told you clozapine is one drug which releases OC symptoms significantly. So I have a little bit of a problem. Uh, no, all EBM comes from practice-based evidence and will continue. Definitely, no doubt about it. But at the same time, my only point is, short term we can give some kind of a trials. When it comes to long term, whoever is preparing algorithms and protocol, they have to be more responsible. I expect, I demand the same kind of a responsibility, which is a lot of you feel this nonsense, but still I say that when there is, like a black box warning about the increased suicidality of antidepressant, it is not responsible, it is irresponsible. It is giving a big handle to people to criticize antidepressants. We don't have anything else otherwise. What do we do? That is where the kind of a thing. BT2, okay, right, sir. EBM is a problem for all practitioners. No, may not be. I don't agree completely. So, see, the COVID period is totally thrown everything out of gear, but but at the same time, this problem they say with the cases series is, I put the case across to you. Tomorrow you're going to see all the case. Tomorrow, maybe day after, when you come back to me next week, some of you may be going to rip me apart saying that why this, why not this, why not this, why not this. If every practitioner is willing to go for that, I'm with you, case based. But sometimes we don't have the data, we are busy. I told you, on and off. When you people see on and off in my database, you say that what nonsense. And then predominant personality, majority of my predominant personality is at OCPD. Then you'll say that what nonsense. And you didn't do any rating scales. You'll say, no, there are certain things, but within the available time, within the my limited sphere, this is what it is. If whatever the data, whatever I'm talking about, if it is agreeable to at least some of you, if you not even agreeable, if this can raise some questions, that is the only thing I want. And independent thinking about it, maybe let me see, check for about few patients and come to that conclusion and you can talk about it. See, we have been talking about mood stabilization, the term being nonsense. CanMat 2018 said remove that. Bipolar 2, I said now 5 years, 6 years back, bury bipolar 2. Now everybody says that bipolar 2 is a myth, remove that. See, things can be, we keep changing it, but at the end of the day, what best we can do to the patient. Lithium once a dose preparation has advantages like less renal harm, better serum levels. Yes, undoubtedly, anything once a day improves compliance, no doubt about it. But my point is, very clearly, sir, I am again saying that lithium it is a short acting half-life. It was given twice a day. When it was given twice a day, the directions came saying that the blood level, whatever we do, is to be 12 hours after the last dose, which is supposed to be the trough, the lowest serum level, trough levels. Perfect. Based on that, they say that 0.6 to 1.2 is the therapeutic range. Perfect. Now, most of us are giving once a day dose. Right? Convenience. When I give once a day dose, the blood level should be taken at, according to me, 24 hours next day, because that is the trough level. It's not the 12 hours level. Even if it is a 10% difference, it is a difference. It's a narrow range. So it has to be done 12 hours. Are we doing it 12 hours or 24 hours? If some of you want, I'll get you a paper just about published 6 months back. Last 70 years, they were reviewing the literature. There is no data on that. Whether it is 12 hours or 24 hours should be taken. Whether it is 0.6 or 0.4, there is no study which is done. That is where it's correct. But when do we do level, and what is the thing which level we have to take it? I'll definitely send the PPT, sir, because I want your opinion. I want your guidance, because there are quite a few patients I'm stuck with. Let me tell you, the challenge, if I'm a good clinician, if I'm worth my salt, if I can prevent these two boys' future episodes, then the efficiency of the clinician, efficiency of the drugs, effectiveness of the drugs, it has got good validity. The third patient, I know that I have not done anything. It's a natural course. That is why I stopped lithium. You remember the very first patient when I continued lithium for 10 years, somebody asked me, why did you continue lithium for 10 years just for one episode of mania? So here I stopped. When I stopped and he has mania, you'll ask me, why the hell you stopped it? Because you stopped, he has got mania. This is the kind of a thing which goes on. Higher dose of lithium cause OC symptoms. I do not know. I have no idea about the relation between lithium and OC. I don't know much about it. Lithium and valproate combination. No, sir. Too many drugs. I think sometime back I told mistaken kindness. Maybe I want to live with mistaken kindness. I don't want to just add on drugs. There's enough data, personal data. And then as I told some of it, valproate is really nothing much to talk about. Nothing much to talk about. Pharmaceutical people will be very angry with me, but still I say that. I'm sorry. Thanks. Most clinicians use more valproate than lithium. Definitely, it's being. Lithium usage is decreasing. Valproate usage is increasing. God knows why. And there are a lot of times we ask questions, why lithium dosage? Everybody talks about this being gold standard. And then people don't write lithium. And case like this, if you see, you people are going to write lithium? When you see somebody was there on lithium for 11 years and he had about 13 episodes, I don't know whether you're going to write lithium, but there's no choice for me. When you say there is no choice, don't subject the patient to unnecessary long-term medication. Short-term, you do anything you want. Long-term, don't say that. So you find an alternative. What is that alternative? Start looking at it from a fresh angle. Completely fresh angle. This is where I said that evidence-based medicine, it's time for you to start listening to the clinicians. Don't sit in your chambers and say that lithium has to be given lifelong. Otherwise, if you stop it, it's not going to be effective. If you discontinue it, it's not going to be very effective. It increases the BDNF levels. It is neuroprotective. I am not bothered about neuroprotection BDF. I am bothered. But as a clinician, I want to see my patient to be all right. Every drug increases BDNF levels. Every drug is neuroprotective. Valproate, there are volumes about neuroprotection. That is where. Let there be a cross communication. Most of the times, the moment a clinician is there, do you have a data? If you don't have a data, shut up. Understandable. Every one of us can't get up and keep on saying that, which is also we have our limitations. And I think, sir, one of the presentations I put a very clearly one. When we talk about this, when we sort of partly criticize some of this evidence-based medicine, let us be very clear that the people who are writing that, they are doing it purposefully. I think it's a beautiful sentence there. It is sometimes because of some problems in the peer reviewing process rather than intentionally it is done. We are only trying to see that, look, you told us this, we told them, look, escitalopram is working, look, reboxetine is not working, like that. But I say that you listen to that, reboxetine is not working. That's the only thing I say, that nothing more than that. Here, why I'm so persistently talking about this is that if that algorithm would not have said that start so-called mood stabilization on episode number 1, I would have shut my mouth. I have no business to talk about it. But that I looked at it saying that it's a little bit of a problem. It's a problem. And when every postgraduate says that, don't give antidepressant, it's producing a switch. Don't give antidepressant, it's going to produce. Hey, what is the scale? Are we scientists? Are we rumor mongering? I've given imipramine and then so much for this patient. Even still, is depressive episodes are much more. Depressive episodes are, I think, 130 weeks. Mania is 40 weeks. I gave him imipramine, desvenlafaxine, and then escitalopram, the whole lot of what you or everybody calls as nonsense. But his depressions are still so much. So those are the things which we need. That is the only thing. Sir, I'm going to send you this paper. And then last slide also, I have requested for some answers. I tried to get some papers. Maybe, so see, sometimes I miss. Sometimes some of the data I may not get. Let us discuss that. Let's see whether this will lead to some kind of some change in thinking, like a kind of a paradigm shift in our way of managing bipolar disorders for the betterment of whatever it is. Ultimately, the patient has to get benefited. And why I'm talking so much is that I think I'm taking too much time also. The symptomatic recovery to functional recovery, there's an excellent study which is showing that the reason why people are not going to functional recovery from symptomatic recovery is significant two factors. One is drug-induced adverse events. Second is cognitive impairment. Drug-induced adverse event is me responsible, AstraZeneca. I give the drugs, I gave the symptomatic recovery. I keep saying that they are not attained functional recovery. And so we need to re-look at that. That's only thing, sir. Compelling need to change acute mania, loading dose of lithium. No, sir. Those days are gone. I don't give loading dose of lithium or valproate. I straight away give this one, sorry, risperidone or olanzapine. Thank you very much. I think it is 10:30. Thanks again. Thank you all. I think so many of you are there with me every week like that, and then a lot of inspiration from you. Thank you so much. I'll send the papers, and the next time I think let us limit ourselves to only discussion on this, and then some of the other questions, maybe another 30-40 questions were there. It's not that I'm going to, I will be able to answer, but let's have some discussion. Some of the things I discussed, and as somebody told that today, I think Dr. Murali got up and told certain very, very useful point. He raised that. Like that, maybe next time we can have some of you talking live also during the session. We'll do that. Thank you very much. Thank you, sir.